Hello, everybody. So glad you're joining us. It's good to see you all. Can I give everybody a couple minutes to all jump in? We have a lot of people here. This is great.
I was hoping I could.
Oh, I see Felicia's on, and she could probably tell us a lot about this too. I think you're another expert. Actually, we have a bunch, so this is great. I see Emma Shea. Hi, Emma Shea. And Jeff is there. Hi, Jeff. Wow, this is a great crowd. Okay, let's see. Ooh, more people signing in. I guess we can just go through those intro slides. Yeah, welcome to Echo. Next slide. As you know, you get free CME in the comfort of your own home, online learning, opportunity for case discussions, and interdisciplinary audience and panel. And we're building a community of learning where we all learn from each other. Next slide. Oh, here it is. Yes. So yes, share your cases. Any geriatric topic will be fine. Not just the ones from here, because sometimes, you kind of free associate and you start thinking about your other patients. And so it's okay to bring up if we want to. But yeah, we have to make sure that, HIPAA compliant, right? Next slide. So yeah, confidentiality, all presentations have to be de-identified, and we want to create a safe learning environment and a culture of encouragement, not negativity, shame, or blame. And just a reminder that case consultations do not create or establish provider-patient relationships. So whatever we talk about here and share with each other is really for the purposes of learning. Next slide. Okay, I think you all know about Zoom. Move your mouse to the bottom of the screen to access the chat and mute buttons. Next slide. Chat tool. Okay, so if you haven't already, please enter your name, your discipline, and your organization, or whoever's with you in the room watching, and that's part of our attendance taking. And next slide. And then there's a mute button. Make sure it is on mute while the speaker is going, but please feel free to unmute when we share. And in order to get CME credits, after you register, you have to complete an evaluation. This link is actually going to show up on the chat box towards the end of the session, so that'll be easy for you to just click on and do it right after the session. And yeah, it's a form fillable, so you can just take care of it and hit enter. Okay, so this is just introductions to our hub team. There's me, I'm the course director for this Echo Geriatrics clinic. We have Mary Gotham. Say hi, Mary. Always good to see you. She's our retired public health nursing expert of many years. And Sarah Tompkison, is she here? Not sure if she could make it, but we have a lot of other people to pull on at this time. Next slide. And of course, we're going to introduce Dr. Lucas Morgan. Yay. Thank you so much, Lucas, for joining us. Dr. Morgan is from Hawaii. Originally, he went away to UMass Boston for his PhD in clinical psychology. He studied mindfulness-based behavioral therapies for anxiety, as well as the impacts of social disadvantage on mental health. He returned home and completed his internship and postdoctoral fellowship with Iola Lahui. It's a local nonprofit focusing on mental health in underserved, rural, and Native Hawaiian communities. He focuses on mental health in older adults and their families, and he's worked with elder care organizations and geriatrician groups, senior homes, adult day centers, and local agencies here on aging. And he works at Iola Lahui, supervising pre- and postdoctoral psychology interns. He loves teaching, which is why he's here too. He has a Geriatric private practice, and he's a master trainer for savvy caregivers. So if any of you have ever have not attended that, I hear it's very good. and you can recommend your patients to that, families. It's a family members caring for someone with dementia. He's passionate about that intersection of psychology, social justice, and culture. And in his free time, he enjoys being with family, working in the garden, and fishing. So without further ado, I'm going to let Lucas take it away.
All right. Thanks so much, Ida and John and Michaela and everybody else for making this, for putting these on. I know I've definitely benefited from them myself. So I'm going to try to share my slides. Does that look good to you? Okay, wonderful. Well, today we are going to have a whirlwind introduction, or sort of covering different aspects of grief and bereavement in older adults. And definitely something that I work with a lot, and I'm just continually amazed at the diversity and complexity with which grief and bereavement issues can present with in the complex creatures that are human beings that we work with, and in my older adult panel specifically. So I know there are, I'm sure, as Aida said, Dr. Wen said, there's a lot of folks in here with a lot of experience with grief as well, maybe even probably a lot more than me. And so I'm going to try to leave some time at the end for folks to add things or correct me if I'm totally off. And I really try, but I'm really bad at managing time. So I'm known for talking and talking and talking. It seems like I enjoy it, but I don't know. Anyway, here I go. So what we're going to do today, we're going to clarify terms, because what are all these words? Grief, bereavement, mourning, all these terms that are related. We'll talk about different kinds of loss, because losing people, definitely one of the major life-changing events in people's lives. And there are many, many other kinds of loss that we can apply these ideas of grief and mourning to. I'm going to introduce a tasks of grief framework that I've found to be simple and helpful framework for helping a patient or client approach, or even just start thinking about their loss and their grieving. I'm not trying to teach anyone how to do a full-on therapy in this 40-something minutes, but this is a little framework that can help approach it. Talk about what is normal grief versus something else, and then we're going to talk about the newest DSM-5 disorder called prolonged grief disorder, which is going to be added to the text revision, the DSM-5 text revision that's going to come out sometime in 2022. Clarifying terms. So grief. When we talk about grief, I think the most useful meaning of grief is the emotions related to some sort of a loss. So if we're talking about grief, we're talking about emotions. So emotions, right? Can be literally any emotions and combination of emotions, right? Sadness and pain, of course, the most typically associated with grief can be relief, right? What if someone who's had dementia for 15 years dies? There can be feelings of relief. Anger, right? Anxiety, what am I going to do now? Numbness, some people don't feel anything, they report at certain times. Guilt, of course. So there is no one grief feeling, there are many, and they are combined, which makes them complex in a given moment, and they change over time. Grief, we can be sort of passive towards grief and sort of like scared of them, or not really want to look at them, or we can be sort of active in our approach to grief feelings, and that often changes over time and can be how providers help a person shift their focus on their grief feelings. And they're often very mysterious, or they're unknown to the person grieving. A person doesn't often know what they feel. Bereavement, okay, this is a sort of a word that's sitting in between the concepts of grief and then the next concept of mourning, okay? So grief being the feelings and associated thoughts, but bereavement can mean bereavement feelings or grief feelings, but it can also be used as this defined period of time during which one is grieving, which is very common in many cultures. Having a bereavement period is the one way that it's used. So it sits in the middle because it can represent the feelings, but it can also represent this thing called bereavement period, which is getting towards mourning, which mourning is an important concept, which is the behaviors done that honor, recognize, commemorate the loss and the grief emotions, the loss of the thing or person and the grief emotion. So mourning is what we do. Grief is how we feel. And bereavement can be how we feel, but also the period of time, which is a form of doing, right? A period of time in which we do certain things, maybe, or wear certain things, depending on your family and culture. So important to start to think about these, use them specifically, and actually help patients maybe to think about these things in specific ways. And I'll talk about why that's important. Okay, so getting into grief. Grief, as we discussed, a range of emotional and cognitive reactions. So emotions being the physiological and emotional, like affect, like sadness, can be crying, can be a hollowness in my chest, or a pit in my stomach, or a heart pounding, or a heaviness in my limbs. Can be cognitive reactions like I should have said something before they died, or why did they leave me? Those are cognitive, right? Those are thoughts. So cognitive and emotional reactions to losing someone or something that we love or value changes over time in different ways. For example, Elizabeth Kubler-Ross, who's one of the sort of pioneers on death and dying, and related to the establishment of the hospice approach to end of life. Grief stages are defined in some of her work as isolation and denial, it should be. So denial, isolation being sort of early stage, this isn't real. Anger, why did this happen? This, why, how dare you? Bargaining, well, what if I did this, or what if I do this? Depression, sort of, this is real, but life is over. And then acceptance of like, wow, this is real. And now I have, this is a new stage of my life. Stages, it's not true that everyone moves through these in this sort of linear fashion. I think they're useful as ideas to think about where a person is in a particular moment. Do they fit into one of these frameworks of feeling? And generally, how do we help people move to acceptance, which is generally a place of, this is the way it is. I'm feeling the things I'm feeling. I'm also going to be, at some point, envisioning what this new reality looks like without the lost person, and then at some point reinvesting in the new reality. And we'll get to that. One of the complicated or complex things is that grief looks and feels different to different people. You may have two siblings, even two twins, let's make it as similar as possible. Two identical twins lose a parent. Those two twins are not going to feel or express their grief in the exact same ways. And one reason is that feelings mean different things to different people. So one patient I had this super strong belief that feeling sad meant that there were things that he must regret about the death. So the sadness was a very troubling thing to him, because he believed, if I'm sad, it must mean that I regret something. So there must be something that I did wrong. And so that sadness was really strongly paired somewhere in his learning history with regret, some belief that if he didn't regret anything, he wouldn't feel sad at the loss of this person. Another person that I've worked with believed that feelings of relief meant that you really wanted them to die, or that somehow you caused it, or that you're a bad person. And so working with folks to try to uncouple these sort of fused beliefs to say that, wow, it makes a lot of sense that you feel relief given how hard the caregiving of this person was, or how difficult this person was to have around. And yet didn't at all mean that you were actively trying to make them die, as long as they weren't, which is of course mostly the case, or that you're a bad person, because relief is so common, and yet it's something that most people feel real shame about and don't talk about. So working in grief, we don't assume what a particular feeling means. We can't assume that, or if we do, we're likely to be missing something. And so, especially if a person is not moving through grief and stays stuck in certain ways, maybe because we're missing particular important meanings behind someone's feelings. So what about mourning? All cultures have ways of helping families, quote, have permission to feel and express grief emotions, to have space to adjust to the loss. So in most cultures, especially these days, it's not okay to like cry in public, right? It's not okay. Although some of us, like myself, can't help it, but well, I'm a psychologist probably, because like I couldn't really help it either. But lot of traditions, lot of rituals, practices, traditions embedded in cultures, almost they create a space that is okay for people to mourn or to cry, to emote, right? Mourning rituals, sort of people having shrines, memorials, offerings, ceremonies, chants, processions, and during these times, it's very common for folks to emote very actively. Wailing, crying, are very common and very okay. And so in modern times, there's sort of a loss of some of these things, which often makes it very difficult for folks who are struggling on their own and not having these socially sanctioned ways to be okay to feel all these things. Curious for you to think about in your own families, your own cultures, what practices, traditions are there that foster these sort of feelings of permission to feel. And maybe at the end we can hear some of those. Visiting graves at memorial anniversaries, that kind of thing. And what else? Many cultures have periods of time for grieving, during which there are symbols that folks wear to help the community know, to give the bereaved folks space to not be okay, right? Some of these different cultures, right? There's 6 months, a year, it's very, just depends on the culture. And different colors, like wearing black or wearing a veil or wearing a certain symbol on your person or on your front door that lets the other members of the community, it just gives the bereaved people permission that you don't have to be your outgoing or gregarious self or whatever is socially more expected. You can be more withdrawn or reserved, because frankly, humans grieving is asking you to, in a sense, slow down and withdraw somewhat, sometimes in some ways, to help you adjust to the reality and the profound consequences of this loss, the emotional reality of this loss, and the body needs time to adjust. And so this is, in evolutionary psychology, this is one of the functions of our ritual funeral practices and bereavement periods and symbols, is to help the body facilitate the movement, the time required for those grief emotions to have time to be processed by the body. Because emotions are not just in the head. Many people don't have strong cultural practices regarding death and loss anymore. That makes it difficult. So one of the challenges as supporters or providers, one thing I do a lot is to help folks come up with their own mourning activities to facilitate active grieving. So no matter when a person has passed, what mourning practices could we come up with that actually help you move towards this loss with this kind of openness? And so it might mean writing letters to the person and burning them and sending them wherever you believe they might go, or going to particular places that the person loves and doing something symbolic. So there's no cookie cutter way to do this, but exploring with the person if they don't have these sort of things can actually help, because how we feel is very, very affected by what we do. And that's the cornerstone of cognitive behavioral therapy, which is the way I'm sort of viewing this. Cognitive affective, the thoughts, feelings, that's grief, and behavioral is the mourning. And so they're all important and all related. So mourning helps a person move toward the grief feeling in order to allow the feelings to move in themselves. Often suppressing or avoiding them keeps grief feelings sort of stagnant or stuck, or converts into other things like anger or irritability or frustration with other things, and doesn't have the freedom to move, so to speak. So working with older adults, I'm sure all of you are very familiar with, and just in your own lives, in your own experiences and families and your own self, changes and losses are a fundamental reality and part and parcel of being human, changes and losses. And so I think it's useful to think about how can we apply the same grief framework to losses that are not just to people that are important to us, but other things. What other losses can we have as we age? Of course, we lose people. That's complex in and of itself. We might lose physical abilities. Routinely we lose muscle tone and strength and stamina as we age. And then different people lose other things like sensory abilities. Losing one's sight is a profound loss that changes a person's reality. And how can we apply this grief framework to that as well? Losing the ability to walk or drive, losing the ability to do something that was central to my identity, that was related to my body. Here's a big one: losing future possibilities. Many of us, maybe when we're younger, when we're in our teens or 20s, we have these ideas about like all the things we want to do in our lives. And as we get older and as life becomes more full and complex and busy, and as we age and as the time ahead of us shrinks and the time behind us extends, we start to feel the very uncomfortable reality that, wow, we're not going to be able to do everything we wanted in our life because just time is not long enough. And so, or things happen, like you lose your legs in a car accident. Wow, okay, you're never going to run the marathon anymore. Well, not in the way you thought you were. But so the loss of future potential, future realities, future dreams is a really big thing that I work on with a lot of folks, really of any age. And there are things that we can use in these grief frameworks that can really help with that. Changes, we change roles, right? Parent, we go to grandparent. Working, maybe retired, or laid off. Married or partnered, we get widowed. I just say that in quotes because same-sex couples or couples that aren't married but committed, one person dies, they're widowed in the sense, even though there's no legal thing like divorce or remarried. So, but those sort of profound role changes can be incredibly challenging because it changes our sense of self and our identity changes, right? When we lose an aspect of our identity through losing our work, that's profound for some people. And so how can we apply some of these same ideas of grief and mourning and change to these struggles as well? All right, coping with change. Change is always hard, or change is often hard. And even a change like a new job or having a baby or moving into a new house, even if it's better in some ways, change is often very, very difficult. So I use this framework, the tier, the tasks of grief and adjustment. And the tier is a acronym. So T, basically the first step is to accept the reality of the loss or change. If a person is not accepting the reality of the loss or change, it's going to be hard to move forward. And so the facts, accepting facts. And we're not accepting thoughts about the future that may or may not be true, like, wow, I'll never be happy again. That's not necessarily true. That's not a fact. That's a belief. That's a thought about the future. But the fact is, this person is gone. Okay, that's a fact. But the fact that you'll never be happy again, that's not a fact. It's a belief. So clear, that gets really tricky when we're trying to figure out even what the facts are sometimes. E, experience the feelings of pain, pain of the loss or change. And so not just pain, but all the feelings that we talked about. E is often the hardest step for both clients, patients, people, and providers, because sometimes providers, it's uncomfortable to go there with folks, or you feel like you're going to harm the person by, encouraging them to allow themselves to feel some of these things with you. And no, this is super, super, super important somehow. And people do this differently, of course. And yet experiencing the feelings associated with the loss or the change is in some way is critical. A is adjust to life without the lost person, or adjust to life with the change, with the new change. And so adjust to that means, wow, okay, this person is gone, or I can no longer drive. And this loss brings up all these feelings: sadness, anger, loneliness, anxiety, fear, guilt. And A is, now that this is the reality of my life, what ideas can I have for how to move forward? So this is the sort of brainstorming that I do with folks a lot about, like, okay, now what? And this is not easy, and there's no easy answers, and I don't have the answers, and we come up with them together. And then we move into R, which is reinvesting in the new reality, which is actually putting your energy into this new life without the person, or without that thing that I used to do. But what else can I do? So this might mean running, if I lost my legs and I can't run the marathon, maybe I'm going to try to do a fun, or some sort of race, like a 10K in my wheelchair. Okay. And reinvesting in that means training with a racing wheelchair, which is something maybe I hadn't even considered before. And with the understanding that these adjustments and this reinvestment might tap into the same values that my former goals had, but the external is changed, so I can't do those. But there might be some same value of pushing myself, of physical health, of competition maybe, but it has to look different now. So ways of, and it's really hard to reinvest in the new reality and to even consider adjustments without spending time in E and experiencing the feelings of pain. You can't just get over it. There needs to be, in some shape or form or fashion, allowing feelings in order to allow the body willingness to even consider life in the next chapter that will be very different. Oh, okay. Wow, I forgot. I go through these in more detail. So accepting the loss or change, loss of independence, and acceptance of the reality is the first step to adjustment and feeling better. Acceptance doesn't mean feeling okay. No. It's a cognitive thing, and it's often something we have to do multiple times a day. It's a practice of acceptance. It's not a one-time and done acceptance kind of a thing. No, that's a myth. Today I accept. Tomorrow, angry. All right, practice, accept again and again and again. Most changes involve, if we don't allow ourselves to feel sad, which is a primary emotion, we might get stuck in a secondary emotion, frustration. And so oftentimes psychoeducation about what are primary and secondary emotions is really important in this step or in this work. We adjust, we slowly change our ideas about the way life or we are supposed to be or should be. Notice if your patient is shoulding on themselves a lot. I should be able to do this, or I should be okay. I'm noticing that you're shooting on yourself a lot today. Let's talk about that. we start to try to think about what we love to do, but in new ways, or how we could do what we loved even without the person, which is really hard to imagine at first, of course. Takes creative thinking, trial and error, and then reinvest in the new reality. Doing things that bring us meaning, purpose, but maybe it has to be done in very, very different ways. Okay, moving on to, is this grief, or is this depression? Is this PTSD, or is this prolonged grief disorder? So these are three other things that might be going on in addition to, or instead of, sort of quote unquote uncomplicated grief. So in the DSM-5, the current edition, I'm not sure what they'll adjust in the text revision coming up. There's a V or Z code named Uncomplicated Bereavement, which is somewhat invalidating if, you know, to most people. Like, most people's bereavement is not simple to them. So I wouldn't advise saying, the good news is you have uncomplicated bereavement. So this is from a DSM. So some grieving individuals may present with symptoms characteristic of a major depressive episode. For example, feeling sadness, associated symptoms, insomnia, poor appetite, weight loss. So it's trying to say that uncomplicated bereavement often and can present with some symptoms of a major depressive episode. And you don't want to be prescribing antidepressants to a person if they don't have depression, because sometimes medications can be ways of preventing or avoiding grief feelings to be experienced, and that's a complicated differential. We'll get into this a little bit. So in the DSM, they give some guidance on this. In grief, the predominant affect may be feelings of emptiness and loss, sort of really centered around loss, versus a persistent and pervasive low mood and anhedonia that may be more typical of MDD. Dysphoria in the context of grief is more likely to decrease intensity over time, and then occur in these sort of waves, these pangs or of sadness and pain, and often associated with thoughts and feelings of the lost person, versus a more global dysphoria that is not primarily associated with the loss itself. Grieving person can still often experience a range of emotions, not always, but often grieving person can still experience this range of emotions versus a more commonly pervasive unhappiness of folks with MDD. So another thing is that in grief, self-esteem is often not reduced, sort of more like you might see with typically reduced self-worth in major depressive disorder. So unless, of course, there's a guilt sort of thing associated with the grief. So sometimes there's a lot of overlap, and yet oftentimes there are things that are not the same. Of course, and I hope you never use diagnoses as sort of cookie cutter things, because that's like using a hammer to brush your teeth. You got to use it in very much more subtle ways or nuanced ways to be most helpful. But if you've lost the ability to feel happy at all after someone died long ago, it may be more than grief. So what are these other things? PTSD. So especially if the loss was traumatic or violent, like an accident, a murder, a suicide, and memories of it keep bothering the patient, maybe it's PTSD. So some questions to ask: are the distressing memories of the loss mostly about the event of the death itself, like remembering events of the death itself, rather than the fact that the person is gone and what that means for your life and everything like that? If it's almost like you have distressing memories of the death event, the day, getting the phone call, if memories are, oh, I remember exactly where I was when I got that phone call, with the voice of the person telling me, your son is dead. Your son was in a car accident and is in a coma. I remember standing by the bedside and seeing the breathing tube in my son's mouth. If I can hear the sound of the ventilator, if these are the content of the distressing memories that keep coming back for the person, Now it seems to be sort of associated also with a traumatic PTSD-like presentation. Another important aspect, does the person try in different ways to avoid thinking about it? So the avoidance of thoughts and feelings can definitely be associated with non-traumatic grief, and yet avoidance of memories and triggers that might trigger memories and feelings is also very characteristic of PTSD. And that's where we're talking about sometimes medications, especially like the fast-acting ones like benzos, can be used by a person to really emotionally avoid sometimes. And don't get me wrong, there's definitely a really good time and place for benzodiazepines, but and things like that. But and sometimes, like any tool, they can be used in not helpful ways. Okay, prolonged grief disorders. Symptoms of clinically significant grief lasting 12 months or longer after the passing of a loved one in adults and 6 months or longer in children. Newest DSM-5 disorder, as I mentioned, text revision coming out in 2022. So grief-related distress that's experienced most of the day, nearly every day for at least a month, and causing clinically significant distress and or impairment. Symptoms may include, and I've seen sort of commentaries and articles about, I haven't really seen the actual, like, this is the quote technical thing of prolonged grief disorder. So it may include identity disruption, feeling as though part of oneself has died, a significant sense of disbelief about the person being dead. Like there are actually times when like a lot of folks who talk to the person when they're alone, or who hear footsteps in the hallway and for a second think that the person is walking into the room, or in the car and they lean over to tell their person something and they're like, oh wait, they're dead, right? But this is, I think, verging more into like moments where the person starts to believe, moments where it feels like they're not dead. Avoidance of reminders that the person is dead, intense emotional pain. Now remember, this is 12 months beyond the person's passing. Continued difficulty with reintegration, emotional numbness, meaningless in life, and intense loneliness, and a belief somehow that someone has actually caused the death, or intense guilt. So the tricky thing is, these things can all happen in quote normal grief, and yet I think prolonged grief disorder, as is sort of indicated in the name, one of the key features is that it's lasting longer than a year, which there had been some consensus somewhere in the development of these criteria that 12 months seem to be, well, if these things are still going after a year, now we're looking at something that is not seeming to resolve as in ways that we would expect if there were not some features that maybe need clinical attention. So grief, and dementias. That's not a different concept. That's a misspelling, sorry. Unique and challenging in many ways because of the complexity of dementia, right? So I do a lot of caregiver work, families, working with folks in early and moderate stage dementia as well. One aspect is the ongoing nature of caring for someone with dementias. You may experience many little deaths or losses along the way of abilities and roles. So when a parent can no longer manage their own finances, sometimes for an adult child taking care of that person, it's like this huge like reality check of like, oh my gosh, this person who was always the financially responsible one, always taking care of things for the family, that part of them has gone, and that role concept has changed and died, and that can be its own little and significant grief, loss. Ambiguous aspects of loss and grief. A person is physically present but mentally and emotionally lost in some ways, but not others. And there's this sort of fluctuating nature, sometimes day to day and definitely over time, but that like mom or your spouse is there in some ways, and definitely physically, but mentally and emotionally. I can't, a person can't really seek emotional support at some point from their spouse who has Alzheimer's, because that person's cognitive capacity is not able to help them be that for that person, and can be a huge loss. Disenfranchised grief is referring to loss that is not socially recognized, where caregivers feel invalidated and alone and invisible. People, well-meaning people, even providers, say like, you should feel grateful that your mom is still here. My mom died at a heart attack when she was 70. Your mom is 96, and she has dementia, but you should feel grateful that your mom has lived a long and full life. And oh my gosh, the sort of horrendous feelings that can sometimes bring up in patients that often don't share that because of how invalidating that can feel. Is just, it's big. And so I really wouldn't suggest going with you should feel grateful if that's something that is practiced where you are or in your families, that often really is invalidating, versus, wow, it makes a lot of sense that you feel that way. Yeah, that makes a lot of sense that you would feel sad and that you're struggling with this so much. Anticipatory grief, fears and knowledge of what may be coming ahead. So of course, that's one barrier to seeking out education about dementia and dementia caregiving, is that people don't want to know sometimes. They're afraid to see what might happen to mom or to husband or to brother. And so, and yet, right, very real anticipatory grief of what might be coming. Reality is complex, so people can present with combinations of all of the above. And that's really why, that's why the work that we all do with human beings trying to help out is so hard. And as a provider, I find that giving myself permission to not know everything is one of the best things that I practice for myself. Because of course, I'm going to try my best, but if I always assume that I don't know everything about what's going on, it leaves my mind open to the possibility that something is there that I can still, learn or figure out, or that we haven't found yet. So people are not islands in that they stand alone. The biopsychosocial and historical, cultural, political frameworks, they strive to include different ecological levels and factors into case conceptualization. And that's what we try to do in a lot of the psychology training that we have. Seek out your own biases. And this is a huge one. We're all ageist, and we all have our own learning histories from whatever families, cultures, experiences with older adults, with death, with losses, or lack thereof that we may have. And so these give us often invisible biases, assumptions, and beliefs about loss and grief and how they should be based on, and the more we can be aware of those, the more we can be sure to try not to be assuming that our way of looking or at things or doing things applies to everybody or the person that we're working with. And this is huge. So many things that can be comorbid with grief and with each other: substance use and misuse, family disruption, conflict. A lot of times if there's inheritance involved, you see the struggle between survivors that can be really brutal and complex. For the surviving maybe spouse, there can be financial stress or housing instability, can't pay the mortgage anymore, no income, what am I going to do? Spiritual or religious doubts that can be part of it. Increased isolation. And I'm sure many of you saw tragic examples of isolation in the context of grief during the COVID era, right? With people in hospital and long-term care settings, often family not being allowed to be with the person in their final time, and how devastating that kind of ripple through family and community. Okay, so again, if we care about someone or something and we lose them, it is 100% natural to feel pain and sadness. So that's one of the biggest hurdles, is that feeling how you feel is okay, is normal, is natural, and means that we can care and love. That's the flip side. If you love something and you lose it, if you actually if you don't care about losing it, I would question how much you love that in some ways. But you know, how you can need to allow those feelings to move, and by being felt and adjust in time to the new reality. Some people fear the sadness. Maybe I'll never stop crying. And so we do a lot of psychoeducation. No feeling has ever lasted forever. No one's ever cried forever that we know of. And encourage getting support. So of course, in the community, in the family, trusted friends, family, if a person has religious affiliations and identities, so religious figures that are supportive. And the key is find people that are non-judgmental and non-advice giving unless a person wants advice. Counselors, psychologists. The key is non-judgmental and non-advice giving unless the person wants advice. Don't rush to medicate grief feelings. As we talked about, there's a complexity really in there. And of course, medications have a place and are very useful and important sometimes, and yet grief itself is not, by itself, is not an indicator for, okay, let's get this feeling away. Support groups, especially dementia and Alzheimer's support groups, can be super helpful, but also there can be different types of groups of folks who have lost someone, like folks who have lost a child, for example. There might be specific support groups that help a person feel like other people can understand a little bit, where most people in their lives, they feel like nobody can understand this. And one key thing about this is that a provider, I can't understand how every person who's grieving feels, but that doesn't mean we can't be helpful and supportive. And it's very sort of limiting to feel like no one can help me unless you know exactly how I feel. And one sort of proof of that to me is that even two people who have lost, like let's say two moms have each lost a 5-year-old daughter. Do those two moms understand each other's experiences and feelings exactly the same? No, because they're both different people. They had different daughters, different relationships to their daughters, different cultures, different families, different ways of relating to emotion. So it's really actually true that nobody can really understand each other. But that doesn't mean that through non-judgmental support and safe space making and exploration that we can't be supportive if a person is willing and ready and interested in that. A lot of books out there, bibliotherapy. So On Death and Dying by Elizabeth Cougaros is a real classic. Understanding Your Grief is one that I use as sort of a workbook, and then there's an associated Understanding Your Grief journal. And I don't make any money off of any of these, just so you know. Grieving Mindfully, application of sort of mindfulness to grief. And really, don't give advice unless it's asked for. That's just a general piece of advice I'd like to give you, even though you didn't ask for it. So take-home messages. Change and loss are a natural part of being a human and of aging. Just as we change from the day we're born, we change until the day we pass away. This lifespan model of development. Grief is a normal part of losing someone we love or something that we value, yet everyone grieves differently. Our bodies are built to grieve because it's been part of our human species since the very beginning and even before. And so our bodies are actually built, the emotions serve that purpose of helping us as human beings, complex human beings, adjust to loss. That's why we have those things called tear ducts. And that's why we feel sad and emotion. We feel pit in the stomach. That's not an abnormal sort of defect. That's part of our evolution. Some way to to actively grieve, to engage in mourning behaviors is really important. It's not a sign of weakness. And again, here's the tasks of grief acronym, that it's not a linear thing. It's not you got to graduate from one to the next. These things can all kind of be happening at once sometimes, but sometimes putting specific frameworks on things can help organize our feelings and the work that we're doing. All right, so there we have it. I'm going to stop sharing and we'll see if folks have any questions or any things they want to add. Oh, I think you're muted, Dr. Wen.
Sorry, just want to encourage folks to, open their cameras as part of when we discuss, so that we can actually see each other. I really appreciate this talk. I didn't learn anything about grief in medical school, and just tried to learn it on the fly here. But this is very helpful.
Thanks.
Wondering if people have anecdotes or stories of some complicated grief or how you help patients. Go ahead, Cody.
Hi, Lucas. Thank you for the talk. You crack me up while also teaching some great pearls. I've had some families that have asked me about if a patient with dementia loses someone in their family, what should they keep telling them? Do I keep telling them that they lost someone they love? And will that damage them somehow if they have to keep experiencing this new idea that this person died? What should they do about that patient, because they can't remember why that person is gone? And I ended up experiencing that with my own family when my grandpa died before my grandma with dementia. And so the family wanted to keep it from her, but when she would sit with me, I would just sit and tell her the news and be sad with her whenever she asked me. And eventually she would remember when she looked at me, oh yeah, grandpa's gone. Have you asked about that have you been asked that kind of question before?
Yeah, Cody, thanks. That's a really, really good question and a really common struggle for families. And I think it sounded like you kind of approached it intuitively. And like when you sat down with her and she asked you, you were compelled to kind of share and you were sad with her, which is really a great thing, that she probably felt intuitively that sadness together maybe helped her process something on an emotional level, even though sometimes the memory is not necessarily still tracking. So it's so hard because there's almost no hard and fast rules about this kind of thing. And there can be situations where it actually ends up being really helpful that someone emotionally connected again and again and again with the person. I think it also depends on when you observe the person's emotional response, the person with the dementia's emotional response. If hearing every single day or every single couple hours that their loved one is dead, if that's causing agitation, anxiety, stress, desire to get up and do things or run away, if you're seeing it cause really distressing and behavioral disturbances, maybe that is not being a helpful thing for that person. And so maybe that might be a time where you are more speaking to the emotional truth of the person missing that person. So maybe you would instead want to try to look at photos of the person together or talk about stories of the person instead of having to really hammer about or decide whether or not to share is the person gone or not. Because even in these repeated questions, there's an emotional truth of that person is thinking about that person and missing them. And so somehow engaging of that emotional truth in other ways, stories, photos, memories, can be validating too for that person. Has anyone else anyone else want to comment on this super good question and complex issue?
I've had similar experiences, Lucas, and you've probably seen that when you have patients that say, I want to go home. I need to go home. And these are the people that A lot of times we worry about them wandering, or we worry about them getting agitated. And I think what's often worked, and it's, again, sometimes, as you know, Lucas, things work and sometimes it doesn't, is how you said, you be present with the person that's experiencing missing home, and being mindful of that. I usually will ask them the question, well, tell me about home. You know, what are some of the things that you enjoy doing at home? And after a while, they actually forget about wanting to go home. And in the same fashion, when you're dealing with grief, I think that important piece you mentioned about talking story and reminiscing with them about, I miss grandpa too, or my husband. And these are the things that we used to do together. We had 6 children and blah, blah, blah. But I think that is a way to not only validate people's feelings, but it also helps with people's emotions and mood that you spoke to.
Thanks, Sarah. Yeah, it's sort of like, it's exactly sort of the emotional truth as you're talking about. So if someone's like, oh, my mom is going to come over and bring over her banana bread. And then it's like, no, your mom died like 30 years ago. Often you see this in sort of long-term care settings. And then a different way to, instead of being like, no, your mom died, look, this is 2021, and having the whole distress, it's sort of like, tell me about that banana bread. How does she make that banana bread? Like, what do you love about that? What else does she cook? And just like, go talk, like you said, talk story, and get like, what are the memories that are coming up that might be eliciting this? So that creative engagement. Thank you, Sarah.
These are really great skills. I mean, I recently had a patient in the nursing home, with the husband was dying and the wife was completely distressed and didn't know what to do. So I really had to sort of help the staff walk her, say, okay, you don't just sit with her and talk to her about the husband and the things they like to do together and stuff like that. The staff needed ideas to know what to do with her, because she didn't know. She was lost herself and she didn't know how to deal with him. I mean, sitting at the bedside and watching him was like, she couldn't deal with that. In some sense, she was actually brought in from home as a respite while he was under hospice care, but because she couldn't stand being home by herself. But on the other hand, being at his bedside, she was completely out of sorts. So we really had to work with this, and yet she had mild dementia. So they had to figure out what to say to her and how to help her cope.
Hi, can you hear me?
Mm-hmm.
My question, so going back to what one of the other people were speaking about, Sarah Tompkinson, about the patient who missed home and wanted to go home. And so there were conversations about home and what it was like. Do you find there's any benefit, or is it more detrimental to say bring photos of home and those sort of things into wherever that person is, so that when she's longing to be home, is looking at the photos has been enough, or do you find that it's still not adequate usually? Or just curious whether seeing it might be worse, or. And
Yeah, this is
curious.
a good question, Naomi. This is Sarah. So oftentimes I won't bring the pictures in. There's a lot of visual changes that happen when people have advanced dementia, but it's like Dr. Morgan was saying, what they're really wanting is they're wanting to talk about, or they're thinking about the feelings and the memories about what home brings. So what we found out is, when we had these conversations, we found out that for the client, she just loved her grandchildren, Naomi, and she looked forward to baking for them and greeting them, and she missed that, and she was really worried about not being home. And then I told her, your grandchildren are still in school. And this was like 6 o'clock, but it didn't matter, right? Because the other piece was, I wanted to give her the peace of mind that her grandchildren were at school, they're safe, they're not going to miss anything. But at the same time, I really need to affirm for her, wow, you're such a special grandmother to bake cookies for your grandchildren. And How special is that? And did you know after 5 minutes of that conversation, she forgot about wanting to go home, because all that was important to her is who the family members were that she loved and cared for when she was in the home. And that's what Dr. Morgan's speaking to.
Thank you so much.
Did that help?
Yes, thank you so much.
Great. Oh my goodness, it's 1 o'clock. I can't believe it. Time has flown by. So I want to make sure that if people want to go, that it's okay. And I'm gonna ask Michaela to put in the chat box the link for the evaluation, so that you guys can get your CMEs. But if Lucas is willing, we could linger just a little longer. Any other thoughts or observations, wisdom?
I have one more. So sorry, because I also have to talk to patients' families when my patient passes away. And I might be the first person to notify them, or I might have to be the one who calls to explain what happens after the patient passes away. And so even though they're not really, my patient, I find that I do a lot of a little bit of counseling or talking them through that initial reaction, and sometimes follow up if that loved one had been in the facility with us for many years. Is there any advice that you would give to healthcare providers when we deal with the families and caregivers?
Yeah, great question. And that's such a difficult spot to be in, I'm sure, because even that situation is endlessly complex based on who the person was and who the family members are culturally and their own relationships. Because as people know, there's a huge variety in the ways families and family members approach wanting to know certain things, and the degree that they want other family members to know or to not know the details, right? And I mean, I guess as a provider, I most often am wanting to offer as much information as is wanted. And so, I'm sort of prone to want to ask the family, what they would like to know. If there's anything I know about their time here and their final sort of days or anything that would they like to know about that. And then just share sort of we call it a hip pocket patient. I don't know if that's used in other fields as well. The hip pocket patient is many families who go through this feel this or XYZ. Many people struggle with this and really don't know how to talk about it. And there are a lot of there are some resources out there that are available. We can look for together if there's anything that you folks as a family feel like you need beyond kind of what you might do as a family, And so if you need any of this, and you can actually list what might be around or the kinds of difficulties that folks kind of go through. It's very normal to feel different feelings: sadness, anger, numbness, kind of just normalize almost anything, And then if you need more support, please be in touch with me, and we can try to help you get connected to something. Anyone else I'm sure folks have a lot more experience with this kind of conversation than me, but.
Oh, Felicia, did you want to say something? You're mute. No, you're not mute, but we can't hear you. Oh, sad. Okay.
Maybe type in the chat.
I just want to recognize that a lot of folks have, in other specialties, fields don't have the luxury of having longer periods of time on a regular basis to work with folks who are grieving. And so that makes it a lot harder to really get into a lot of the complexity that folks with an hour a week or something like that have more of a luxury to do. So just want to recognize how challenging it must be. And so, yeah, we gotta be a team, right? Yeah.
Right. Oh, Felicia says, as a professional doing that first call, it is also important to center and ground yourself before the call. Yes, thank you for the reminder. Yeah, don't be rushing in there with a million things in your head. Yeah, that would be terrible. Yeah.
It kind of points to the importance of the provider's own self-care and self-awareness, and sort of being, because it's so hard to sit with pain sometimes, especially when you are also stretched too thin or you're struggling with your own pain. And so, and just knowing that where you are and how you're feeling and what you're doing. And I think the grounding, Felicia, is a great idea, a suggestion in that situation and in many other times as well. So, because you are a big part of how that goes yourself.
All right. Thank you, everyone. Thanks so much, Lucas, for this really, engaging and thought-provoking and helpful discussion. All right. Hope to see you guys.
Thanks, everyone.
Bye.
Bye.
Don't forget to do the eval.